Thanks for the planning committee for inviting me to come and speak today. Also like to thank one of my colleagues back home, Dr. Andy Ayub, who has basically given me a bunch of slides to use here today, so that disclosure is there. I also want to thank everybody as you get your ARS devices out to actively participate. So before we get started with the ARS cases, I'd like to share a few basic concepts that I share with our residents to help them understand the disease process of torsion and volvulus. I like to let them think about the process more holistically. So first, I tell them about the predisposing factors, such as congenital abnormalities, where the attachment of the pedicle to the body wall is abnormal. So, such as the case of bell clapper deformity, where the testicle is allowed to torse around within the scrotum. The second area of abnormality or predisposing factor is the acquired abnormality of the pedicle itself, such as the redundant sigmoid colon in a chronically constipated patient, which allows for sigmoid volvulus. And lastly, I like the residents to think about the predisposing factor of the organ itself. So if there's a problem such as an ovarian mass, that can cause a lead point for things to torse around. So with that said, hopefully everybody has had time to get their devices open. This movie will loop, and I'll let it play for a couple of times. The first case is a 65-year-old woman with a history of COPD abdominoplasty presenting with abdominal pain. And if you're using your iPhone device, sometimes you have to press play to allow it to go. Okay. All right, so here's the ARS question. So what CT finding is present that suggests the increased risk for bowel ischemia? And so is it A, transition point, B, small bowel diameter greater than 3 centimeters, sorry about that, C, air fluid levels, or D, Whirl sign? So we'll give everybody a few seconds. Okay, great. This is an easy question, I guess. So let's see. All right, everybody got that. So yes, correct. It's the Whirl sign, which is demonstrated in the middle of the CT image on the previous slide. And to reemphasize some of the points made by the previous talker, by Dr. Soto and all, there are imaging findings that make you more concerned about bowel obstruction, or two, concerned more about ischemia. As previously referred to, Dr. Paulson and Thompson clearly outlined both the radiographic and CT findings of bowel obstruction in their radiology article. One of the charts of the article demonstrates the CT findings that are indicative of obstruction that we're all familiar with, and they separate them out into major and minor criteria. That same article has an additional chart that outlines the findings that may suggest ischemia. And as you can see, the Whirl sign is an independent CT finding that's associated with ischemia. And Duda et al. Showed that when the Whirl sign was present, it was approximately 25 times more likely to have small bowel obstruction requiring surgery when compared to those with obstruction without the Whirl sign. So hopefully I won't send anybody into seizure activity here, but there are two playing videos. This goes along with Dr. Melnick's presentation. We have a 72-year-old gentleman with a history of vomiting. We'll move on to the diagnosis live question. Maybe? Okay. So which of the following describes the findings? So A, organoaxial gastric volvulus, B, mesenteroaxial gastric volvulus, mixed type gastric volvulus, or a sliding type hiatal hernia. Okay, and I think Dr. Melnick and I are sending mixed messages because most people are getting this wrong, so maybe I'm wrong. So the correct answer is B, mesenteroaxial gastric volvulus, where the antrum rotates above the fundus and the GE junction along the short axis of the stomach. So as you can see, there are three main subtypes of gastric volvulus that can all present with obstruction. And I think we all agree that the obstructive process is what really is important when you're talking about gastric volvulus. And like Dr. Melnick said, the predisposing factors here are typically because there's laxity in the gastric ligaments or enlargement of the space containing the stomach, such as in diaphragmatic hernias, defects, or eventurations. So just to spend a little bit more time on a study that was done by Dr. Melnick's group at Mallinckrodt, which showed the most sensitive signs for detecting volvulus are a transition point at the pylorus and stenosis of the hernia neck, as we can illustrate in this companion case. You can see that there's stenosis here at the hernia neck, and this other case of volvulus, there's a transition point at the level of the pylorus. And unfortunately, this was not reported as volvulus, and the patient returned about a week later with frank perforation and gastric ischemia. So unfortunately, this patient passed away prior to definitive management, but we can use this case to learn about some of the signs associated with gastric ischemia pointed out by that previously mentioned study. And they found that perigastric fluid, pleural effusions, and gastric wall edema were present in some of those cases that indicated ischemia. All right, let's move on to the next case. We have a 71-year-old male who presents to the ER with abdominal pain and bloating. Here's his supine abdominal radiograph. We'll move on to the diagnosis live question. I think, okay. So here's his corresponding CT. So which of the following CT signs related to colonic volvulus is present? So is it A, the X marks the spot sign, B, split wall sign, C, beak sign, or D, whorl sign? This one's a little bit more challenging, I guess. All right, good. I couldn't give all easy questions. So this is actually the split wall sign, and we'll get to the explanation of that in a few images here, a few slides. So of course, this is a sigmoid volvulus, and we can see the classic beak sign that we see on this therapeutic water-soluble enema. And the predisposing factors for sigmoid volvulus, like I previously mentioned, are generally thought to be acquired, associated with conditions that enlarge or dilate the sigmoid colon. While the other side of colonic volvulus, the cecum, is generally thought to be secondary to anatomical variations of peritoneal fixation or an acquired mass or adhesion, or maybe a combination of these things. And the reason I chose this case is basically to illustrate some of a few of the subtler signs of CT sigmoid volvulus. So the so-called split wall sign, where you have a small amount of fat invaginating in between two walls, where you just have a little bit of a fold of the sigmoid colon. You know that there's a obstruction, but maybe you're not seeing the classic signs that you can see. So this is the so-called split wall sign. And an article from 2000 in AJR by Levsky et al. Basically shows you how you get this little tiny bit of fat in between two opposing walls. And so that's this sign right here, okay? The other kind of more subtle sign that you can encounter is the X marks the spot sign, where you are basically scrolling up and down axial images, and you see a crisscross pattern of the sigmoid colon. You don't see necessarily the twist, but the bowel is going at 180 degrees opposing each other. Of course, these are the signs that we're more used to seeing. The beak sign you can see on CT as well, and you can also see that sigmoid mesentery whirling around. Okay, so here is a 38-year-old female that came to us in the ER. She was pregnant, and we saw a big mass on ultrasound. And we basically said, we see a big mass on ultrasound. So she was admitted, and she had this corresponding MRI. So here's our diagnosis live question. What's the most likely diagnosis here? Is it a heterotopic ectopic pregnancy, serous cystadenoma, ovarian torsion, or sigmoid volvulus? So a little bit of a split response here. And maybe people think I'm trying to be deceptive, but this is a talk on ovarian torsion. So if you go along with that, you can see here that this is a twisting of the pedicle. This is actually the right ovary that's over on the left. If you had eagle eyes, you could notice that the left ovary was down here in its normal position. So this was, of course, a case of ovarian torsion that on ultrasound, we only saw a big cystic mass. In the case of ovarian torsion, the predisposing factors may be secondary to abnormality in the organ itself, like this case, where there's either a big functional cyst or a benign cystic neoplasm. The predisposing factors can also be secondary to the pedicle itself. So if you have very hypermobile pelvic ligaments, like we see in children, that could also be a predisposing factor. Just to remind everybody, the more typical appearance of ovarian torsion that we diagnose on an ultrasound, the ovary is almost always enlarged, so typically greater than 4 centimeters in one axis or 22 milliliters in volume. This typical appearance of peripheral follicles and echogenic or slightly heterogeneous central stroma is there. You do need to be careful with Doppler just because of the variability or the potential for dual arterial blood supply to the adnexa. So if you have ultrasound findings, grayscale findings that suggest torsion, then you should make that diagnosis. Again, this is just to re-emphasize the CT finding of the CT and MR findings that you can see of the twisted pedicle. Other findings are you have a mass. This is a big teratoma that twisted towards the midline. So the ovary can be enlarged with or without a mass, as in this case of torsion, the ovary is enlarged. Another finding that you can notice is that there could be abnormal enhancement of the ovary or ovarian hemorrhage. Okay, so this is a more challenging case. It is a 10-year-old male with 3 to 4 days of left testicular pain. Pain is going into the groin. He noticed some swelling, reddish purple discoloration, mostly today, and now the pain is worse with palpation. Okay, we'll go on to the diagnosis live. This is a 2-part question. This is a touch question, so if you will use your device to touch the area that you think is abnormal. Good. This is another mixed response question, so some room to learn. Okay, so let me click on. All right, good. Most of the people were between the two abnormalities. So that's very good. So with that information, let's go on to the next diagnosis slide. So the yellow is the actual area of abnormality. So with that knowledge, what's the most appropriate next step in management? Is it antibiotic therapy, antiviral therapy, conservative pain control, or orchiopexy? Okay, that's a pretty good response rate. So the answer here is just conservative and pain control. And for all of you who made the correct diagnosis, this is torsion of the appendix testes or the appendix epididymis. And then you correctly chose the management, which is conservative pain control. So many times on physical exam, the ER physician can see a focal area of discoloration in the scrotum. So it's always fun for us to, when we make this diagnosis, to ask the ER resident or physician to go back and check and make and see if there is some discoloration. And if there is, they think you're really smart for a little bit, and then they go on to their usual. So this is a nice segue basically to remind us of the more common pathology we see in the scrotum, which is, of course, testicular torsion. And the predisposing factor, like I alluded to earlier is for intravaginal torsion, that the pedicle's attachment to the wall is abnormally high. So it fuses, the fusion of the tunica vaginalis is high and allows for the bell clapper deformity. And as a reminder, we really hang our hat on ultrasound with Doppler imaging as the primary imaging modality to make this diagnosis. And here is a case that illustrates that importance of identifying just asymmetric blood flow. As you can see that there's a diminished but preserved blood flow to the right testicle on this case, seen best on the side-by-side or buddy view. And unfortunately, this patient was discharged, came back 5 hours later with this ultrasound, and where you can see that there's completely a lack of blood flow now to that right testicle. And you can see the marked abnormality, asymmetry of blood flow. Again, this is a reminder that that we really need to use the Doppler for testicular torsion as in contradistinction to ovarian torsion. Sometimes when we get confused, we can also look up into the upper scrotum, into the inguinal region, and you can see this torsion knot where you basically are following the spermatocord, and as you follow it, it takes an abrupt change in caliber or direction, or you can even see it twisting. Okay, this is the last slide. This is a 13-year-old female with history of dextrocardia, lung disease, abdominal wall reconstruction, kyphoplasty, presents with abdominal pain. So this is a typical UK patient. And sorry for the rapidity or the quickness of the image. I tried to slow it down here. Okay, we'll just move on to the diagnosis live question, which is a word cloud. So just type your diagnosis in. Remember, you are logged in, so the offenses can be traced back to you. Okay, I think that's good for the word cloud. All right. Wow, we have a potpourri of of answers here, but right here, tiny, right here, this is a case of splenic torsion, okay? So typically, in splenic torsion, what happens is the spleen is allowed to wander because there's either absent or complete absence of the ligaments or lack supporting ligaments. This was taken to the OR, and the spleen was completely infarcted, and it was reported to be 720 degrees of rotation of that spleen. So thanks again for your participation and the opportunity to present to you guys today.